Welcome to the deep dive. So if you're listening, you're probably getting ready for that huge jump into your third and fourth year clerkships. You're moving from, the clean world of textbooks to the much messier reality of the exam room. Our mission today is to take a stack of clinical guidelines, some deep pharmacologic sources, and really break down irritable bowel syndrome into clear, mechanism-based knowledge. And you will see IBS all the time. You might even be tempted to think of it as a minor diagnosis. But our sources are really clear on this. It's the second highest cause of work absenteeism.
Just behind the common cold, it's staggering. And for the patients, it's this profound drain on their quality of life.
Exactly. So to make this real, we're going to anchor our analysis to a single case, Debbie. She's a 30-year-old nurse. She's had this persistent GI upset since she was a teenager, but it's gotten a lot worse lately. There's some major psychosocial factors going on. Financial stress, marital problem.
The gut-brain axis in action.
Absolutely. She comes in with severe, recurrent abdominal pain and frequent loose stools. So our deep dive is going to map her experience right onto the diagnostic criteria and then walk through the pharmacologic journey for her specific subtype.
And what you've just described in Debbie, that's really the hallmark of what we call a functional GI disorder. Irritable bowel syndrome, by definition, is a chronic, often debilitating functional disorder of the GI tract, and it's characterized by that combination you mentioned: chronic abdominal pain and altered bowel habits. The key word there is functional. It means the symptoms are very real, but they exist without an identifiable structural or biochemical cause we can point to.
Which, for a student, means your first job is to rule out all the scary stuff.
Exactly. You're thinking about inflammatory bowel disease, celiac, even malignancy. You have to exclude that organic pathology first.
Okay, so let's get into the clinical picture. When you're taking a history, what are the core symptoms that should make you think, okay, this sounds like IBS?
They really fall into two big buckets. First, there's the pain. It's almost always a chronic abdominal pain. Patients describe it as cramping. The intensity varies, but the critical link is its relationship to defecation.
So it gets better or worse after a bowel movement?
Precisely. The pain is either relieved or sometimes it's actually made worse by passing stool. That's a key feature. And the second bucket is the altered bowel habits. This can swing wildly from one extreme to the other. You might see frequent, loose, small to moderate volume diarrhea, or you'll see the complete opposite: hard, pellet-shaped constipation. And sometimes it's an alternating pattern, which can be really frustrating for the patient.
And what about the other symptoms that usually come along with it?
Oh yeah, you'll almost always hear about significant bloating, a lot of gas, something called tenesmus.
That feeling of incomplete evacuation.
That's the one. And sometimes mucus discharge as well.
Before we diagnose Debbie, let's just hammer home those red flags. What are the symptoms that should make you stop and say, wait a minute, this is probably not just IBS?
You have to be vigilant for these. Our sources call them alarm features. If a patient reports large volume diarrhea, any blood in the stool, nocturnal diarrhea, so diarrhea that wakes them from sleep, or any unexplained weight loss,
You have to broaden the differential.
immediately. You cannot make a diagnosis of IBS until those high-risk signs are worked up and ruled out.
Makes perfect sense. Okay, so we've excluded the red flags for Debbie. Now, how do we take her subjective complaints, the pain, the loose stools, and turn that into a positive objective diagnosis?
We use the Rome-Foist criteria. They are the gold standard for this. The criteria require recurrent abdominal pain, on average, at least 1 day a week in the last 3 months.
Okay.
But that pain has to be associated with 2 or more of the following. 1, it's related to defecation. 2, it's associated with a change in stool frequency. Or 3, it's associated with a change in stool form or appearance.
All right, let's apply that to Debbie. She says her pain is a 7 out of 10, and it consistently gets better right after a bowel movement. So that's number 1, checked. She averages 2 to 3 bowel movements a day, which is a change in frequency for her. That's number 2. And she reports very loose, non-bloody stools, at least half the time. So that's the change in form. She meets all the criteria.
The diagnosis is confirmed. She has IBS. But as you know, that's only half the battle. The treatment depends entirely on subtyping it.
Right. And to do that objectively, we need the Bristol Stool Form Scale, the BSFS.
Absolutely. You can't just go on a patient saying it's loose.
The BSFS is such a great tool for that. It gives you a number from 1 for, severe constipation to 7 for liquid.
Okay.
It's objective.
Yep.
So how does it help us subtype?
It's beautifully simple. It's all based on a 25% rule. If 25% or more of abnormal bowel movements are type 1 or 2, that's hard, lumpy stool, You've got IBS with predominant constipation, or IBS-C.
Okay.
If 25% or more are type 6 or 7, that's the fluffy, mushy, or watery stool, then it's IBS with predominant diarrhea, IBS-D.
And if they meet both criteria.
Then you have IBS with mixed bowel habits, or IBS-M.
So for Debbie, who reports very loose stools, consistent with type 6 or 7, at least half the time, her diagnosis is crystal clear.
She has severe IBS-D.
And for her, the therapeutic mission is now fixed.
Mm.
We have to slow her transit time, reduce secretion, and get that pain under control.
And don't forget her background, a working nurse under high stress. The strategy has to target the diarrhea, yes, but it also has to improve her ability to actually function at her job.
Right. So let's talk treatment for IBS-D. We always start with diet and lifestyle modifications, of course. Stress management is huge, especially for someone like Debbie. But when that isn't enough, we turn to meds.
And first line is loperamide.
Everyone knows loperamide, but what's the exact mechanism? Why is it the go-to first step?
It's a synthetic peripheral mu-opioid receptor agonist. So it acts only in the gut, which is key. By hitting those receptors, it does two things. It inhibits peristalsis, which prolongs transit time.
Slow things down.
And at the same time, it increases water and electrolyte absorption from the colon. It works fast, you can dose it as needed, or even before a known trigger, like a stressful event.
But here's the catch for Debbie. Loperamide is great for stool consistency, but our sources consistently highlight that it does not reliably help with the global symptoms, specifically the abdominal pain.
That's the major limitation, and for many patients, the pain is the worst part. It's what keeps them from work.
So if the pain is still there, or the diarrhea isn't fully controlled, what's next?
Then we move to second line, and this is where it gets interesting because we start thinking about underlying pathophysiology. We often trial bile acid sequestrants, something like cholestyramine.
Okay, that feels like a bit of a leap.
Yeah.
Why are we giving a drug for high cholesterol to a patient with diarrhea? Explain that connection.
It's a crucial clinical pearl. Up to 50% of patients diagnosed with IBS-D might actually have a concurrent condition called bile acid malabsorption, or BAM. See, normally, bile acids help with digestion, and then they get reabsorbed in the terminal ileum.
Right.
But if that reabsorption process is faulty, the excess bile acids spill into the colon, and those bile acids are incredibly irritating. They act like a laxative, stimulating secretion and motility.
So they mimic the exact symptoms of IBS-D.
Perfectly. So by giving a sequestrant, an agent that literally binds up those bile acids, we stop them from causing trouble in the colon. It's a really targeted approach.
That is a great takeaway. Okay, so for severe refractory IBS-D, where Debbie is missing work and these options aren't cutting it, we bring out the heavy hitters. Let's start with the safer one, rifaximin.
Rifaximin is fascinating. It's a minimally absorbed antibiotic that acts locally in the gut. You give it as a 14-day course. The idea is that it modulates the gut microbiome, maybe knocking down some bacterial overgrowth or dysbiosis.
And clinically, what's the effect?
It's often very good for improving those associated symptoms like bloating and just the patient's overall sense of well-being.
We're going to circle back to the other big gun for IBS-D, Elostron, in a bit, because it needs its own safety discussion. But for now, let's pivot. Let's look at the opposite problem. The IBS-C patient.
Right. For IBS with predominant constipation, the goal is the exact opposite. We need to accelerate transit, soften the stool, and, crucially, increase intestinal fluid.
And the first step here is usually an osmotic laxative, polyethylene glycol, or PEG. The mechanism is simple physiology, right? It's an inert molecule that just sits in the gut and pulls water in via osmosis.
Exactly. It increases stool bulk, softens it up, improves frequency. But just like loperamide on the other side, PEG has a major limitation in IBS.
It doesn't help with the pain.
It doesn't. It's great for the constipation itself, but it typically does not significantly improve the abdominal pain or the bloating, which, remember, are part of the core diagnosis.
So if PEG isn't enough, we escalate to the prescription secretagogues. And this is where, as a med student, you really need to know the cellular mechanisms. We're not just passively pulling in water anymore.
Now we are actively forcing the gut to secrete fluid. And we have two main classes of FDA-approved drugs here. Let's start with the chloride channel activator, lubiprostone.
Okay, so what's its specific target?
Lubiprostone directly activates the type 2 chloride channel, or CLC2. These channels are on the apical surface of the enterocytes, the cells lining the gut. When lubiprostone hits that channel, it flips a switch, causing an immediate efflux of chloride ions into the intestinal lumen.
And basic physiology tells us where chloride goes,
Sodium and water have to follow. They rush into the lumen along that electrochemical gradient.
creating this chloride-rich fluid that lubricates everything.
Precisely. It acts like an endogenous lubricant. It increases motility, softens the stool, and shortens transit time. It's a really elegant mechanism.
That makes perfect sense. Now for the second class, because this mechanism is, as the sources say, twice as nice, the guanylate cyclase C agonists, linaclotide and plecanatide.
Right, so these drugs target a different receptor, the guanylate cyclase C or GCC receptor, also on the luminal surface. When the drug binds to GCC, it cranks up the concentration of intracellular cyclic GMP, or cGMP. And that rise in cGMP kicks off two very cool, very distinct effects.
Okay, effect number one is secretory. The increased cGMP activates the CFTR channel.
The same channel that's dysfunctional in cystic fibrosis.
And that activation pumps out chloride and bicarbonate, and once again, water follows. So you get that same fluid secretion we saw with lubiprostone, just through a different pathway.
Exactly. But it's the second effect that is the real clinical game changer. There's good evidence from animal studies and supported by clinical data that extracellular cGMP may actually dampen the activity of the visceral pain-sensing nerves in the gut.
So it might have a direct analgesic effect. It's not just fixing the constipation, it's treating the pain.
Potentially, yes, which is a feature that most other laxatives just can't claim. So if your IBS-C patient's main complaint is that terrible cramping pain, a GCC agonist is probably a superior choice.
That really highlights why knowing the molecular target is so critical for picking the right drug. Okay, we have to go back to the severe IBS-D patient, like Debbie. We have to talk about the powerful but high-risk therapy we put a pin in earlier. Allocentrone.
Allocentrone. It is a selective 5-HT3 antagonist. Serotonin 5-HT is a massive player in the gut. It regulates motility, secretion, visceral sensation.
Everything.
Pretty much. Allocentrone works by blocking the 5-HT3 receptors on those enteric afferent nerves. This does two things. It decreases the brain's perception of visceral pain, and it dramatically slows down colonic transit.
It sounds incredibly effective, and it can be, but it's highly restricted. It's only for women with severe IBS-D who have failed everything else. And the reason is that black box warning.
Everyone needs to memorize this. The primary life-threatening risk is ischemic colitis.
A severe reduction of blood flow to the colon.
Yes. It's rare.